Welcome, I'm Terry Tropin, and today I will be discussing CPT coding for critical care services. First, let me tell you a little bit about myself. I have a master's in healthcare administration, informatics from the University of Maryland Global Campus, and I have RHIA and CCSP certifications. Also, I'm an AHIMA approved ICD-10 trainer. I taught health information technology at Montgomery College for over 20 years. I've also written books on coding. Here they are. These are based on study guides I did for my students. So I have Evaluation and Management Coding Made Easy, ICD-10-CM Coding Guidelines Made Easy, ICD-10-PCS Coding Guidelines Made Easy, and a small book on changes to ICD-10-CM and PCS code books for 2024. All of these are updated to 2024, and they're available on Amazon. Okay, so here's an overview of what I'm going to talk about today. To tell you the truth, if it was up to me, I would delete all the critical care codes and make a new section with all the critical care codes grouped together. That would make it so much easier. Unfortunately, it's not up to me. So here's what I'll discuss. First, what is critical care? And then an overview of the critical care codes. And then a couple sections on why is critical care coding so hard? Why is it so complicated? Then I'll talk about outpatient critical care, inpatient critical care, and critical care transport. First, what is critical care? Well, for a critical care, a patient has critical illness or injury, single or multiple vital organ system failures, and a high probability of imminent or life-threatening deterioration in the patient's condition. So what constitutes a vital organ system failure? It could be central nervous system failure, circulatory failure, shock, renal, hepatic, metabolic, and/or respiratory failure. So it's a failure of a major body system. Now, critical care typically, but not always, requires interpretation of multiple physiologic parameters and/or application of advanced technology. So all of these critical care codes include high complexity medical decision making. So that's where you start. They must have high complexity medical decision making or you can't use them. The codes are determined by location of the services, whether it's inpatient, outpatient, or patient in transport, like in an ambulance, from one facility to another. Whether the services are face-to-face with the patient or non-face-to-face. For example, these are true for transport services. And the age of the patient. Are they neonatal, pediatric patients, or older patients? So different codes depending on where, face-to-face or not, and the age of the patient. So let's say, why is critical care so hard? Well, one of the problems is the codes are in 3 different areas of the CPT book. Critical care services, 99291, 99292, that's one section. There's another section not close to the critical care services section at all for inpatient neonatal intensive care services and pediatric and neonatal critical care services. Now within this section, there's a section for pediatric critical care transport and inpatient neonatal and pediatric critical care. So this is a separate section. Finally, there are one other code in the other emergency services section, 99288. Here's another reason critical care is so hard. It depends on the age of the patient. Over 24 months, under 24 months, age 2 to 5, over 5. So it depends on the age of the patient. Codes 99291, 99292 are, I think, most confusing because they can be used depending. They can be used in outpatient care for a patient any age, inpatient care for patients over 5, and transport services for patients over 24 months. So you'll see these codes pop up in each of the sections as I'm talking about them. Some codes are reported only face-to-face. Some codes are reported only for non-face-to-face. And some codes are reported for face-to-face and non-face-to-face services. And in this case, these are inpatient services that are face-to-face with the patient and non-face-to-face, such on the patient's floor or unit, still working for that particular patient, but not face-to-face. So why is critical care so hard? Another reason is some codes are reported using minutes, some codes are reported using per day. So, and 99288 has no time component at all. So you have the minutes, 99291, 99292, and 99466, 67, 85, and 86. And codes reported per day, 99468, 69, 71, 72, 75, and 76. So you have to be careful. Am I reporting by minutes or per day? Finally, one of the problems with critical care services is that the guidelines are very, very specific, detailed guidelines, but they're buried in long paragraphs. So you have to really look carefully to point them out. I would go through and underline what is important in the guidelines, but they're just long, long paragraphs. There are also very specific guidelines for reporting critical care with other services on the same date. If the patient is not in critical care, they need critical care, or the other way around, and do you report both services or do you report only one? So how do you find critical care codes? So these are the questions you need to ask yourself. Where is the patient? How old is the patient? And was this encounter face-to-face or non-face-to-face or a combination of it? So that you need to have these before you can decide which set of codes to use. So let's start with outpatient critical care services. These actually are the easiest. So these are reported using time. Remember, the medical decision making is always high. You can use these codes for outpatient critical care services, any age, in settings such as a physician's office, a hospital, clinic, emergency room. Codes may be reported over multiple days if the patient's condition continues to be critical, even if the treatment stays the same. These services are face-to-face with the patient. So here's how, this is the time, 99291 once per date for first 30 to 74 minutes. 99292 is each additional 30 minutes, so it's add-on code. And if it's more time than this, you can use it 99292 multiple times to capture all of the time. Now the time may or may not be continuous. The patient may be receive care for 2 hours in the morning and then 2 hours in the afternoon. So you add all that together. So it may not be continuous. It must, of course, be recorded in the patient's medical record and must be spent providing direct care to an individual patient. So the provider is focused on this patient when giving the care. Now, there are specific guidelines for when a patient received care in more than one setting for 99291, 99292. So say the critical care was given in an outpatient setting and then the inpatient setting on the same date by the same patient. So outpatient setting, and then they say, we got to admit this patient. So it's the inpatient setting. So what they're saying, the guidelines say use critical care inpatient codes for all services on that date. So you add together the services outpatient, services inpatient, and only report inpatient care. So what if critical care is given in an emergency department and it was completed, then the patient's condition worsens and then they're admitted to inpatient critical care. Use both emergency department codes and critical care codes. Now look in the first one, they were all wrapped up together, outpatient, inpatient, reported one code. For emergency and inpatient, you report each separately. So this is why you need to really go through these guidelines. So what if the patient is in intensive care and then becomes critically ill? Intensive care is a lower level of care than critical care. And then the patient is referred to another physician in the same group practice. That's the important part. Physician reports initial critical care codes only. This is another physician in the same group practice. Okay, so this is an interesting but confusing thing, unlike most codes in CPT. This is a list of services included in the outpatient codes. I'm not going to read them all, they're in your book. Note, however, that providers may not report these codes. These are included, but facilities may report these codes separately. So that's important too. So let's move on to inpatient critical care, and here are the codes for that. Inpatient critical care services usually, but not always, are provided in a critical care area such as a coronary care unit, intensive care, pediatric intensive care, respiratory care, or emergency facility designed for emergency services. These services are provided face-to-face with the patient or non-to-face. So they have face-to-face and then non-face-to-face for time spent on the unit or floor providing services, organizing services for the patient. These codes are selected using the age of the patient and time. Medical decision making, once again, is always high. There you go. So these codes are selected by time and the age of the patient. So 9946869, patients 28 days or younger. 9947172, patient 29 days through 24 months. 9947576 for patients 2 through 5. 99291, 99292 for patients older than 5. So here again, we see 9929192, which we talked about for outpatient, but is also used for inpatient services if the patient is older than 5. Okay, I don't know why my clicking's not working. So the total time may not be continuous. Again, a couple hours in the morning, a couple hours in the afternoon. You just add all that time together. Time must be recorded, of course. Time must be spent providing direct care to an individual patient, either at the bedside or on the unit or floor. So you can't count time on the unit or floor when they're dealing with something else, having a cup of coffee, whatever. It includes minutes spent at a patient's bedside or floor or unit. What are they doing on the floor or unit? Well, they may be reviewing test results or imaging studies or discussing the patient care with medical staff, like giving orders, for example. So different codes are selected using time. So 99291, 99292 are reported by specific minutes. 99291 once per date for first 30 to 74 minutes. 99292 for each additional 30 minutes. So once you hit that 74 minutes, once you hit 75 minutes, you can start reporting 99292. It can be used in multiple units. 99468, 69, 71, 72, 75, and 76 are reported per day. So these are reported by minutes, and these are reported per day. It doesn't say specific times, it just says per day. So all the time in the same day. Okay, again, sometimes multiple services are provided to the patient on the same date. So for example, patient received outpatient and inpatient care, use the critical care inpatient services for all services on that date. Patient's emergency department care completed, patients continue to worsen, then requires critical care, inpatient critical care, use emergency department and inpatient care. Patient received both critical care and hospital care or intensive care from one physician or group. So several different types of services. Use only code for critical care services. So again, the guidelines are very specific. You need to review these. So again, sometimes inpatient critical care on the same date. So say the patient, a newborn, receives normal newborn services, and then something horrible happens and they require critical care. The guidelines say report 99468 with initial critical care with modifier 25 and a code for the newborn service. Patient age 28 days or younger, discharged from critical care, then readmitted to critical care. So they're in critical care, they're stabilized, they think it's going to be okay. They're discharged from critical care, moved to a different setting, but then worsens and they're readmitted to critical care. So use subsequent inpatient critical care for the readmission. So you don't go back to initial critical care. They've already got critical care, they're discharged, they go back, and in that case, it's subsequent. So here's another possibility. Patient age 29 days through 24 months, discharged in critical care, then readmitted. The guidelines say use code 99472, subsequent inpatient critical care for readmissions. Kind of what we said before. Inpatient younger than 6 years receive care in both outpatient and inpatient. Use inpatient critical care codes for all services. So again, they're all added together. Okay, so let's look at another possibility. Patient in intensive care then becomes critically ill. Patient referred to another provider on the same date. So another provider. So the referring provider, the one who was doing the first care, reports only one code, such as time-based intensive care codes, hospital care service, normal newborn, whatever they were doing. And then the receiving individual, the one the referring provider sends the patient to, can do critical care codes. Okay, multiple providers may provide care during the same hospital stay in same facility. So let's look at this possibility. They're in the same facility. That's the important part. Same facility. So you got provider A, who provides critical care services, then transfer the patient to provider B, who provides a lower level of service, intensive or subsequent hospital care. The transferring provider, that first provider A, uses subsequent hospital observation care codes or critical care codes, depending on what they were doing. Receiving provider uses code for the lower level service, whatever service they were providing. If the patient is then readmitted to receive critical care from provider A, then this provider again uses subsequent critical care. Doesn't start back with initial. You can only do initial once per hospitalization. So in this case, multiple providers but different facilities. So care provided to patients younger than 6 at 2 separate facilities, physicians, different groups. Referring provider transfers patient from their facility, use inpatient care, critical care, 9929192 based on time. Okay, the receiving provider takes the patient in another facility, and they can use the inpatient critical care codes 99468, 71, and 75 based on per day services. So this one's doing per day, and this one's doing time. Okay, again, we have the list of services included inpatient critical care codes. Note again, facilities can report these separately, but providers may not. These are the same services listed for outpatient with some additions. The services listed after temporary transcutaneous pacing were not included in the outpatient. So it's the same ones except for the addition of these 5. Okay, the third type of critical care service are transport services. So the critical care patient is being transported from one facility to another, usually in an ambulance, right? The original facility may not have the equipment or the staff to provide for this patient. So there's different codes for where the provider is. If the provider and patient are together traveling in the vehicle, you have 99466, 99467. If the provider is at another site, the patient is in the vehicle, the provider is directing the emergency staff to how to take care of the patient. But the provider is not in the vehicle. That's 99485, 86, and 99288. So some codes are used when the provider is physically in the vehicle with the patient. These are reported by time and age of patient. Again, medical decision making always high. So you have codes for 24 months or younger and over 24 months. So 99466, 99291 are reported once per date for the initial 30 to 74 minutes. 99467, 99292 are add-on codes used for each additional 30 minutes per date. And again, these can be done in multiple units if appropriate. There you go. So time, how do you count time? Well, time begins when the physician assumes primary responsibility for a patient at the referring facility. It ends when the receiving facility accepts responsibility. So it's all who has responsibility. While the patient is traveling, the physician has responsibility. When the receiving facility and they accept and they start taking care of the patient, the time ends. It includes only time spent face-to-face with the patient during transit. Okay, this is for when the provider is in the vehicle. Don't use these codes if time is less than 30 minutes face-to-face with the patient. Use other appropriate code. Okay, again, we have the list of services included in patient critical care. Note that the facilities can report them separately and providers may not. These are the same services as listed for inpatient services with one additional service listed here. This one right here. Okay, so the same services. Okay, so what about if the provider is not in the vehicle? So the provider is in the facility and is directing the emergency medical system personnel to provide emergency care and advanced life support. The patient is being transferred from one setting to another. These, of course, are non-face-to-face services, and they're determined by the age of the patient. So we have 24 months or younger and over 24 months. Okay, so what services are included? This is different than the ones we've talked about before. Here are the services, the supervision of these services. They're being provided by the EMT services, EMT personnel, but they're being directed by the physician. Telemetry of cardiac rhythm, cardiac and or pulmonary resuscitation, endotracheal and esophageal obturator airway intubation, administration of fluids, administration of drugs, and electric conversion of arrhythmia. Okay, as stated before, critical care codes are confusing. So make some possible notes in your CPT book to make them a little easier. This may seem like a lot to write in, but you will be so glad you did. First, let's start with code 99291. Write in there, outpatient critical care, any age, inpatient care over 5, for other inpatients, C 99268. Critical care transport, face-to-face, patient over 24 months, for other patient transport, C 99288, 99466. I would recommend that when it says like C and refers to a different code, write in the page number where that code is, because I don't know about you, but I spend a lot of time trying to find the code because they're not in numerical order and they're hard to find. So just write in the page number and then you'll be able to flip to that page immediately. I don't have the page numbers listed here because I have a professional version. You may have a different version, so I don't know exactly what page it's on in your book. So write in the page number, write in these, and then write in the page number. Then also in the introduction to 99291, circle the paragraph beginning for reporting by professionals the following services, and that lists all those services we had before. And also underline the wording, facilities may report the above services separately. Okay, so let's go on to come on, there you go. At 99468, which is inpatients, write in patient 24 days or younger. For inpatients 29 days through 24 months, see 99471. 2 years through 5 years, see 99475. Over 5 years, see 99291. And again, write in the page numbers for these codes, see such and such. Write it in, it'll make your life so much easier, so much faster. And again, go to the introduction to this section that says invasive access procedures, that paragraph, circle that. That gives you the procedures that are included. And also write in, underline, facilities may report the included services separately. Okay, then turn to 99471, which is also inpatients. Write in patients 29 days through 24 months. For patients 28 days or younger, see 99468. 2 years through 5, 99475. Over 5, see 99491. These seem repetitive, but it will really help you out if you do this. Again, put in the page numbers. Circle the paragraph beginning with invasive access procedures and then underline the wording facilities may report the included services separately. Okay, now turn to 99475, inpatient. Write in patient 2 to 5 years old. For inpatients 28 days or younger, see 99468. 29 days through 24 months, see 99471. Over 5, see 99491. Circle that paragraph, invasive access procedures, which gives you the services included, and then underline facilities may report the included services separately. Okay, turn to 99288, which is a transport code. Write in critical care patients in transport over age 24 months, provider not in vehicle. Okay, so patients 24 months or younger, see 99485. Face-to-face transport, see 99466. And again, circle the introduction section, that paragraph beginning with includes but not limited to, which is a list of the services included in this code. Okay, 99285, also transport code. Write in critical care patients in transport under age 24 months, provider not in vehicle. For patients over 24 months, see 99288. For face-to-face transport, see 99466. And again, put in those page numbers. So 99466, also transport. Critical care patients in transport under 24 months, provider present in vehicle. That's under 24 months. So for patients over 24 months, see 99491. For non-face-to-face, see 99288, 99485. And then again, circle that introduction section with includes but not limited to for the services that are in there. Okay, so that is it. That's what we've got. Covered a lot, but very important changes, and I hope this makes it clear. It's so confusing, and if you write in your book, it'll be so much easier to find what you need. So here are the books I've written on coding. And here's what they look like. I have Evaluation and Management Coding, which takes each section of codes and explains them thoroughly. I have a book on CM, a book on PCS, and a book on the 2024 changes to CM and PCS. All of these books have been upgraded to 2024. So if you have questions or comments, you can contact me through Facebook, email, and if you'd like a copy of these slides, give me a thumbs up on this video and send your email address to me at terry.tropin@gmail.com, and I'll send you a PDF of these slides. Thank you so much for listening. I hope this was helpful.